So basically, I'm trying to touch upon basically the practical aspects of NIV. Theory, of course, you can learn from books. Sometimes you can get it from internet also, but practical aspects, especially with regard to current situation, and then the available devices in our country. I thought talking about those things will be much more practical because you'll be using the knowledge, I mean, the stuff I tell you, so that you can, when you see patients and you have with your devices available, then so I'm trying to focus more on the type of devices we have and the kind of NIV we can do in our country. So now, non-invasive ventilation, I hope all of you have seen what non-invasive ventilation looks like. So we basically use a face mask, which is fairly having a good seal to the facial contours. And then we use that with certain devices to give some support to the patient's breathing in the way of, giving a pressure support to the breathing. Now, so this can be done in various ways. You can use different devices. You can use different masks. So we'll try to learn how NIV, what NIV is, and how we can practice applying NIV. So basically, there are two main varieties of NIV. This actually started with patients with sleep disorders, and people were like, obstructive sleep apnea. So people wanted to keep their pressure inside the throat fairly high so that it won't collapse during their sleep. So these devices actually originated in domestic environment and then later on came to hospitals. So most of the devices still in Sri Lanka, actually, because of the lack of certain mask types, we're actually getting certain older category of masks. So you have to be careful when you use them. So I'm going to touch upon all those types of masks. So basically, initially what they wanted is to have some kind of positive pressure developed in the throat so that when they go to sleep, when they are in deep sleep, the throat won't collapse and obstruct the airway. So that is actually, that was called Cpap, because what they wanted was a continuous positive airway pressure so that patient can still breathe. And they have some way of exhalation, but at the same time, you maintain a certain positive pressure in their throat. So that was the idea of having a CPAP. So generally, so when the patient breathes, so this pressure, which is outside the patient's mouth, so oral airway opening, so we use a certain tight-fitting mask and we use a device to pressurize gas, and we maintain a certain pressure. So that pressure will help inhalation or inspiration. But when the patient tries to exhale, that pressure will not change, but it will still be there. So the patient will have to use a certain degree of higher force to exhale than a normal situation, like when the mask is not connected. So CPAP is not actually a very big deal because the pressures we use in CPAP is generally slightly lower values. And then so patients can still breathe in and out, but it won't kind of help to increase minute ventilation a lot because exhalation is slightly affected. It might sometimes in certain patients can affect the washout of carbon dioxide. But generally, this will help the patient to have a higher lung volume and sometimes can recruit certain collapsed alveoli because of the positive pressure. So this helps to sort out some of the oxygenation or the oxygen issue. And you have a type 1 respiratory failure where your oxygen levels are low. CPAP is, so they started using CPAP to help these oxygen problems, but basically started with the sleep apnea. So the devices, most of the devices were used in domestic environment, which uses kind of a very low oxygen, sometimes no oxygen at all. So I mean, if you look at the NIV devices nowadays coming to Sri Lanka, some of the devices cannot be connected to oxygen, and they sell it still to the hospital because people are desperate. And we'll talk about them later. But for the moment, CPAP is a continuous positive airway pressure. So how if you look at the pressure tracing in a Cpap device, so in this chart, I have mentioned pressure here in the y-axis, and x-axis is time. So it basically maintains. So in this example, I have shown a Cpap or continuous positive air pressure of 10 centimeter water, which is a fairly moderate kind of pressure. So for example, so that will help the patient take in the breath, but it will slightly obstruct the exhalation. So when the patient breathes, so during inspiration, so you can see this is actually this during inspiration, the patient takes a certain patient can inhale, so the pressure slightly drops, and then the pressure raises when the patient tries to exhale. But the ventilator or the Cpap device will not give any support to the inhalation. So it will just maintain that pressure. So when the patient is breathing, there can be a certain fluctuations of pressure, but in certain devices, you can't even see this fluctuation because it will certainly maintain a constant positive airway pressure at the mouth interface. So this is kind of helpful, as I told you, in hypoxic conditions. This will not augment the inspiration. So when the patient is breathing, it will not increase the pressure. It will just maintain that pressure throughout the respiratory cycle. So it will help oxygenation. So it, as I told you, this ventilator provides a constant pressure, and patient breathes on top of that pressure. And there can be minor pressure fluctuation due to the breathing efforts. A ventilator does not actively support inspiration or exhalation. So when you compare that one to BiPAP, so that is actually, so that older devices, they use Cpap. So they use various kind of devices to provide Cpap, but the later devices, they added what we call BiPAP because the Cpap did not support the inspiration and did not support exhalation actively. So now here what we do is we maintain, like a Cpap, we maintain a baseline pressure. So the ventilator senses when the patient tries to breathe, so that the ventilator can actually, so that this baseline pressure, like in a Cpap, will help to inhale, I mean, have a higher lung volume in the sense of functional residual capacity, like, so when you breathe in and out, when you breathe out, usually the volume left in the lung is called functional residual capacity. So that is where you get oxygen stored in the lung until you take the next breath. So you will improve oxygen because of the positive pressure. There are two main pressures we talk about in BiPAP. One is called expiratory positive airway pressure. It's called EPAP. It's almost, I mean, it's similar to the Cpap we discussed. So it's kind of a positive pressure applied in the baseline. So when the patient tries to breathe, when the ventilator senses, so it increases the pressure, what we call IPAP, or inspiratory positive airway pressure. So this process itself will help the inspiration. So it assists the inspiration. And certain devices, they don't have this EPAP, IPAP mentioned. So if you have a normal ventilator with what we call spontaneous mode or Cpap pressure support mode, we call it. So you can use this spontaneous mode with the Cpap, and you can add a pressure support, what we call pressure supports, in a normal ventilator, and you can still get a what we call a BiPAP kind of ventilator. But in dedicated BiPAP devices, it's used as EPAP and IPAP. So these names, they actually mean this, I mean, similar thing. So you can use a Cpap pressure support, or you can use a BiPAP device which displays these two pressures. Whatever it is, what really happens is you have a baseline pressure. When the patient tries to breathe in, so the ventilator will increase the pressure to a higher level. So basically that is what it is. So you can just sort out the names later on, but basically you have a baseline pressure, and when the patient tries to breathe, the pressure is increased. So these two pressure levels are called inspiratory positive air pressure and expiratory positive air pressure. So when the patient tries to exhale, the ventilator senses the exhalation and it drops the pressure back to the baseline. So that itself will help exhalation. So when you try to breathe out, there is a pressure drop, there is a kind of a negative pressure developed, so that you can easily exhale. So BiPAP when compared to Cpap, actually it helps both inspiration and expiration. So it is kind of the ideal device when you have a work of breathing issue, like in a COPD patient, and even in pulmonary edema, although people use Cpap, still you can use BiPAP, because it helps inspiration, it helps exhalation both. So wherever if you need to increase oxygen, so if the patient is desaturating, so what you need is actually to increase what we call EPAP, or expiratory positive air pressure. That is what actually recruits more and more alveoli. That is what actually increase the functional capacity or increase the lung volume and recruit the alveoli, and that increases the oxygenation of the patient. That will improve the saturation of the patient. So so whenever you need to increase oxygen, so you can actually increase the FiO2, the fraction of inspired oxygen we can give, but at the same time, increasing oxygen is just a temporary measure. It won't help any underlying condition. So you remember that one, oxygen will not cure any underlying problem. It is just, just to increase FiO2, but the EPAP or the Cpap will recruit more alveoli, will open up these collapsed alveoli, will increase the lung volume, and it will help to sort out some of the underlying issues. So the ideal thing is to, first you increase the FiO2, but secondly, with that one, you have to increase the EPAP if there is an oxygen issue. That is the standard approach, but depending on the patient's situation, these things, the things might change, but generally that is the general approach. But if you need to wash out more carbon dioxide, in the sense you need to give more volume to the patient's lung, then you can actually increase this gap. If it is a CPAP pressure support, normal ventilator, if you are using a standard ventilator, you can increase the pressure support. Or if you are using a BiPAP ventilator, you can increase the IPAP, so that the patient will get larger tidal volume, better tidal volume, because you increase the pressure to a higher value during inspiration. So that is what BiPAP is. So basically, BiPAP helps both inspiration and expiration, and improves work of breathing, and it will help to clear out carbon dioxide, or it will increase the ventilation. So that is kind of a better device in a critically ill patient, especially when they are trying to breathe harder. So that will unload some of this work of breathing, and it will help most of the time compared to BiPAP. But if you look at the literature, there are certain instances where both cases, both CPAP, BiPAP is helpful. But as far as possible, if you can sort out BiPAP, and if you don't need that much of pressure support, you can reduce the pressure support, but BiPAP always reduces the work of breathing. So I would generally advise to go for BiPAP, but it's, you can read the guideline and then go according to the guideline. Basically, one of the most important things is to understand that all these intubation, BiPAP, CPAP, it's not a specific treatment for any disease. Like, it's not a treatment for ARDS, it's not a treatment for, say, so if you have to correct the underlying problem, if there's a lung collapse, you have to improve. If there is a pneumonia, you have to give antibiotic. If there is ARDS, you have to minimize lung injury. So this ventilation or the NIV or invasive, none of these ventilation, they are not a specific treatment for any underlying disease. So it's just a bridging therapy. You just try to save the patient's life until you sort out the underlying issue. That is the most important message you want to get, because we provide oxygen, we use NIV, but we should not damage the patient's lung, and we should not expect the NIV to sort out everything. So you have to do the underlying, you have to manage the underlying problem. So NIV is just to keep the patient alive until you sort out the underlying issue. Now, nowadays, because of this pandemic, intubation and invasive mechanical ventilation, because it demands a lot of higher level of skill. Not everyone can intubate a patient, especially a dyspneic patient, and obese patients. You need a lot of skill. So nowadays it's not that widely available, because you have a limited amount of skilled people to do that. So NIV actually was started. People started using NIV because it's easy to apply and it's very short learning curve, and you can always remove and reapply if you go wrong. You can just always reapply. And so the NIV use actually grew almost exponentially. Then everyone is using NIV when you need to escalate from a normal oxygen therapy. So NIV is one of the most commonly used modality. And the indications and the devices, there are diverse kinds of devices in Sri Lanka. And the outcome will depend on various factors. There are evidences on certain indications where they say this is definitely indicated in, for example, BiPAP. They say in COPD it's very helpful, and Cpap is useful in pulmonary edema. Even BiPAP is useful, but certain like hypoxic condition like COVID or pneumonia, generally NIV is not very useful. But there are reasons why it is not that useful. But at the current moment, this is the kind of most one of the most useful device because of the lack of skills to intubate and the places to keep these intubated patients. So NIV is kind of indicated at the moment in the COVID because on this desperate situation. Now, if you look at the difference is outcome, but we actually use the same ventilator in our Sri Lankan setup. In ICU ventilators, we use the same ventilator to intubate and ventilate, and we use the same ventilator for NIV. So where is the difference? I mean, so we use similar pressure settings and we use similar devices, and tubings are also the same. The only difference is the mask interface and the tube. So theoretically, if you use the same pressures and you don't have a significant leak around the mask, theoretically there should not be a big difference in outcome. But there is a difference in outcome. One is because the NIV patients are awake and we cannot control their tidal volume like in a ventilated, intubated patient where we can paralyze and control their tidal volume. We can control how much lung damage they are causing. But NIV, it's kind of difficult. But there are advantages in both either these things. So we'll try to focus on. So first of all, I'll just try to point out how an invasive one compared to a NIV, because invasive ventilator, so this is the ventilator, and like in a normal person, if you get a normal person breathing through a mask, say face mask or Hudson mask or Venturi mask, they have the freedom of flow. For example, if they want to generate a peak inspiratory flow rate of 35 or 40 or even a higher flow rate of 50, so they have enough air in the environment, so there is no flow limitation. They can get the flow. I mean, oxygen is a problem, but the flow is not a problem. But when you connect a person to a ventilator, it's a closed system. It's not an open system like a. So unless there is no free flow of gases flowing through the ventilator, the patient must tell the ventilator, or the ventilator must give a certain flow. They have to open these valves in the ventilator and provide the flow. Otherwise, patient is going to suffer, because if the ventilator is not sensing the patient's breath, and then the patient is trying to breathe, then patient is in trouble because he's not getting any flow. The ventilator has to open all these valves and provide flow. So the ventilator should be capable enough to sense the patient breathing and time it accordingly. Otherwise, patient is going to struggle to breathe. That is why we need to sedate these patients on an invasive ventilation. Whereas in non-invasive ventilation, there is a lot of leaks, and actually you get compulsory leaks to wash out the carbon dioxide in the exhale gas, and you get generally, I mean, you can't stop all the leaking through the mask because, and sometimes you have leaks in the tubing compulsorily made for exhalation. So it is, and the other thing is, so in the NIV compared to a non-invasive ventilation, so even if you try to tighten the mask, patient can generate, I mean, get some kind of air through these leaks. So it's not a completely closed system, but it's fairly close if you have a tighter fitting face mask. But there is some kind of freedom of breathing. So these patients do not need that much of sedation. You generally don't sedate NIV patients. You don't need to sedate. So you apply NIV on a conscious, alert, or cooperative patient compared to a unconscious patient. You are not going to apply NIV because you have to have a patient's effort and drive to breathe. So the patient should be breathing properly. Then you are just going to support the patient breath. When the patient tries to breathe, then you increase the pressure. When the patient exhales, you drop the pressure. That is how the BiPAP or NIV BiPAP works. So how do you improve the mask fit? Now, so people think if you tighten the mask as much as possible, people think so that is the best way to have a better seal. So that might provide a better seal, but sometimes if you tighten it too much, so for example, if you tighten this lower straps too much, the patient might leak from the upper area. If you tighten this one too much, so he might leak from the lower one. So it's quite important to select the proper size of the mask so that it won't leak from all over the place, and then tighten it uniformly. So the key word is uniform pressure around the mask, not the tight. You have to tighten, but it's not the tightest fit. So if you try to tighten it too much, then you get ulceration in this nasal area and in facial areas also, and it's uncomfortable. The person will not tolerate, and you must be experiencing how it feels to have a N95 mask for the entire day, and imagine how a tight mask for many days. When the patient struggle, don't try to blame the patient because it's quite uncomfortable. So it's extremely important to have a uniform fit rather than a very tight fit to have a success in NIV. Otherwise, they will struggle, and when they struggle, so when they are not cooperating with the flow from the ventilator, and then it won't work properly, so, and you won't get any benefit described in the textbooks or in the literature if the patient is not cooperating. So it's completely useless if the patient is not cooperating. So it's extremely important to explain the patient what is going to happen and how the patient would feel. And you start with the lower kind of pressures and then ascend up. But at the same time, you have a proper selection of mask, and then the proper size of the mask, and then proper pressure application. If you tighten it too much, then it's not going to work. Okay. Okay. Then there are different kinds of mask interfaces. Some have gel interface, which I have found that it's not the best in most of the instances. But if you have a soft silicon, this thing, so actually it helps to minimize the pressure damage, and it's much more comfortable. And the other thing is with the flow, so it will conform into the contours of the face much better if you have a soft silicon edge. Anyway, so there are good masks with gel margin also, but anyway, so you have to see the different types of masks. So, and it's extremely important, the counseling. So there are working theories, there are ethical theories. Generally, I use a certain technique. I don't know whether it is completely ethical, or I just explain the patient. If the patient does not comply, there are two options when the mask, normal Hudson mask, or the other oxygenation measures fail. One is to intubate, where you can't eat and drink, and you are being sedated, and it's kind of more damaging to the lung in certain ways, in certain instances, and it has got more consequences or morbidity. But if you can comply with this mask, which actually delivers slightly high pressure gases, but if you comply with the mask, then you can avoid getting intubated, and you can take the mask out and eat and drink and put the mask back on. So it's more comfortable. You can communicate with your the relatives. So they generally tend to respond much better, because they know if they do not try to comply, then they will have a much kind of dire consequence. But when you have to explain when the patient is actually well conscious, like when they are not in too distress. So when you plan, you have to plan ahead and tell the patient this is what is going to happen, so they can actually adjust to the oncoming things in time. Otherwise, if you just take the mask and explain, probably they won't comply. And when the patient is extremely dyspneic, so some of these patients will not tolerate the mask because they are not having a good mentation. Anyway, so how to adjust the settings? So when there is oxygen problem, so what you can adjust is, you can adjust the FiO2. There is a button to set the oxygen concentration, or you can just increase the EPAP, as I told you, or the Cpap, the same meaning. And then you can increase that to increase oxygen. And if you need to say increase the ventilation or wash out carbon dioxide, the patient is not generating enough tidal volumes, you can always increase the IPAP. But there are limits, you can't be increasing IPAP to 40s, 50. So you have to select which patient to increase. So we'll talk about in a minute. And then the same thing, pressure support is equal to this difference of EPAP and IPAP. So the gap is pressure support. So you can increase the gap when you need more ventilation, when you need to wash out carbon dioxide. You can increase the EPAP or Cpap when you need more oxygenation. Simply, that is what we do. There are so many settings. I'm not going to details because so this lecture is generally for the RHOs who have got no experience in NIV in most of the time. So I'm trying to simplify, but still I have to tell certain things. So if the other guys are listening to this lecture, probably, they can help when these people are actually trying to do it. So this knowledge can be dispersed to the RHOs once again. Because if you listen once, sometimes once is not enough, even a couple of times, sometimes this topic is kind of a little bit confusing. So I'm trying to simplify. So when you want to increase oxygen, there are two main things. There are so many things, but with the ventilator, the FiO2 and the EPAP or the Cpap. But of course, the clearing out secretions, physiotherapy, there are so many other things, the positioning, the patient is, hunched over. So you can actually position, there are so many things. But with regard to this mechanics of this NIV, the FiO2, the EPAP are the two main settings you can change as a setting. So always look at the patient. The machine is not the priority. Look at the patient, what is happening to the patient. That is what you should actually practice. So this is about a certain scenario. I'm not going to do details. This is what happened to a patient because we did not select the proper mask. So this is a lady which I had in my ICU, severe pancreatitis, multiple organ failure, ARDS and everything. And patient survived after prolonged ICU stay. And we had a difficulty in weaning. So I extubated the patient onto a non-invasive device like a BiPAP. And then patient improved well, but she had probably some kind of lung problem post prolonged ventilation in the ARDS. So she maintained a certain lower saturation, but she was otherwise absolutely okay with no associated symptoms. And without oxygen, she was saturating around 90-92, but she was completely otherwise symptom-free. Rate was slightly high, but otherwise she was okay. So I sent the patient to the ward and advised them not to give oxygen just to get the saturation up if the patient is maintaining 90 and above, and the patient is asymptomatic, and to let us know. But anyway, because saturating was hanging around 92, medical referral was done, and they have advised to start Cpap. But the patient deteriorated gradually day by day, and they actually one day they actually sent me a blood gas and asked me whether it was a Pickwickian syndrome. I said I can't just comment on blood gas. So I actually went to the ward to see this patient on a separate different kind of mask. So this was actually the blood gas, the pH was okay. The carbon dioxide was 72 because the patient could not breathe out properly because the patient was connected to a improper this is the mask the patient was on. Because, this is not, nobody tried to intentionally harm the patient, but they have stolen mask from the ICU because the ward people also needed a mask. So this mask was supposed to be in the ICU. This is called a non-vented mask. There are no ways of exhalation, and patient was connected to a single limb circuit where there is no other way of exhalation. So they have been tightening the mask to the patient's face, and patient is getting exhausted and even about to have kind of respiratory arrest because patient was too exhausted. And then what I did was to remove this mask and apply the different kind of mask. So we'll try to, this patient had a very nice outcome. Then the same day patient was, in the afternoon, patient was perfectly okay. So I removed all the masks, and so patient could go home the next day. Anyway, so we'll learn about different kinds of masks. So here in Sri Lanka, I don't think we have this full face mask covering the entire face. That is not very common in our country. But so the initial masks were nasal devices like in here. So this is the domestic devices applied for obstructive sleep apnea. This is what the device we use, but it is actually available in certain hospitals. And don't try to use this device in a critical ill patient. This is just for obstructive sleep apnea. I have seen in certain peripheral hospitals, some people actually use this device. I was astonished to hear that when I went to do a certain workshop, and they only had this device. And they have tried to apply them on certain critical experiments. So this is the device Italian people used, the helmet device, which is, I don't think it's widely available in our country. But this is the mask, type of mask, full face mask. We still call it full face mask or the face mask, NIV face mask. This is a commonly available device. So we'll try to see what these devices are, because nowadays we are getting so many kinds of devices. Now, so when you select a mask, so there should be a way of exhalation. Now, generally in ICU ventilator, you have two limbs connected to a mask, where you can inhale through one limb and exhale through another limb, and that limb is connected to an exhalation port. So that in the ventilator, you have an exhalation port. For example, in the ventilator, you have inspiratory and expiratory limbs. So this limb is connected to a patient's airway, and then and the other limb is connected to the expiratory limb. So the patient can exhale through this one out. Now, in a mask and in some of these portable devices, they have only one limb that will continually provide flow to the face mask, or sorry, the NIV mask. So if you use a mask where there is no exhalation port on the mask, for example, in this mask, I don't know whether you can see there are certain holes in the mask, so that patient can exhale. So this is an absolutely essential thing to figure out how the patient exhales. So different type of mask, so that mask I just showed you initially, that did not have an exhalation port. So you have to have a way of exhalation either in the ventilator or in the mask or somewhere in between in the tubing. So you can attach an exhalation port. So some way of exhalation should be available. That is extremely important, especially for non-trained people. So when you use a mask, this is the number one thing. So especially if you haven't used NIV devices and you try to ventilate a patient in the ward, COVID patient, and you have got some certain ventilators which you don't know how to operate, and you use a mask where there is no way of exhalation, the patient is going to suffocate. So it's extremely important to figure out how the patient exhales. So if you have a ventilator device like in ICU type of ventilator, easy job, you just connect the non-vented mask. So I'll tell you how to identify. So basically it's important to figure out. So now these are two different masks. So this is actually vented mask, means you vent all the exhale gas through these holes. I don't know whether you can see the holes. There are so many multiple holes in this mask. So this is called a vented mask, because the exhale gas is went out. Now in COVID, this is not a good device, because the patient will exhale all the aerosols through this vented mask. So this is actually not recommended in a COVID situation, but this is the usual device which you connect to a portable single limb devices, which is most widely available in our country at the moment. So those machines are designed to be used with this vented mask. Now that is a problem, because the most commonly available portable BiPAP devices in Sri Lanka are having a single limb circuit, and then you have to connect a vented mask, but it's not recommended in a COVID situation. So what you can do is to attach a exhalation port over here, and a filter also over here, an exhalation port, and then use a non-vented mask. In this mask, there is no way of exhalation. So you have to either connect to a dual limb circuit, where there is, so the ventilator connected to the ventilator, so the patient can inhale through one limb, exhale through another limb. So you don't need an exhalation port in this non-vented mask. Generally, the non-vented mask, they have a blue shoulder. The vented mask has a white shoulder, but it's not a compulsory thing. Sometimes I have seen in certain masks, you have a white shoulder and still it's a non-vented mask. So it's extremely important to figure out which type of mask you are using, and And so in COVID, use a non-vented mask all the time, not a vented mask. Don't use vented. You get vented mask with the devices, but don't use vented mask in a COVID patient because it can generate a lot of. Okay, now this is how we can use. So this is an unvented mask with a white shoulder. So you can attach a bacterial or viral filter over here so that when the patient exhales, so you get virus-free exhalation gas, and you can attach an exhalation port over here. So forget about the green one over here, that is to enter in some more oxygen. So forget about that one. So the purple one has got a small tubing, small opening like this, so that patient can exhale through that one. So that's not a very comfortable way of exhalation. Anyway, that is the option if you use a single limb circuit, because the devices you have most of the time have a single limb device. So you must have an exhalation port. So this is the option in a single limb circuit. So these are the kind of devices. You can have a single exhalation port, or in certain with the ResMed device, this is what you get in a commonly you have multiple slits for exhalation. So the exhalation is fairly possible. And then so single limb devices are common because it's easy to for the patient when they come. It's less bulky, and then but the problem with if you use a say vented mask, then you are exposed to the aerosols. So I'm just gonna skip this one, this non-asphyxia valve for the moment, because if I have time, I'll just come back to this one once again. So how do you use an unvented mask? So this is also an unvented mask. This is ICU type 1, but you can attach a filter like this at this end, and then an exhalation port like the purple one to be used in a single limb circuit. But dual limb circuit, you don't need that one. You don't need this exhalation port in a dual limb. So you just connect a filter and the dual limb circuit. So what are the devices available to apply the BiPAP? So you can use standard ICU ventilator. That is what we use all the time. Or you can use specific dedicated NIV ICU ventilators. Unfortunately, I haven't seen a single dedicated NIV ventilator in Sri Lanka. All these devices you use and you think they are NIV devices, they are domestic devices. But ICU devices, they are quite expensive. So this is a normal invasive standard ICU ventilator. And this is how a standard, NIV specific ventilator looks like. This is a Philips device. This is extremely, the expensive devices. But you can also use invasive ventilation, but this is specifically designed for non-invasive. I haven't seen, this is probably available, but I haven't seen them in practice. So these are the kind of portable ventilators we have in our country. One of the commonest one is this Flight 60. I'm mentioning the name not to promote them because they are available in the country, and most probably you will use these ventilators. So this is not just to promote any of these devices. I'm not, for the companies. I'm just mentioning the name because it will be useful, because you can read about these things, because these are the kind of devices available currently in our wards. And then this is the kind of one of the most commonest NIV devices used in Sri Lanka. So I'll go into details about this device because there are certain problems and uses of this device. These are called portable. These are low flow actually. You can generally, this is connected to a 15 liters per minute. High flow means if you can achieve your peak inspiratory flow rate, that is a high flow device. If you cannot achieve, that's a low flow device. So this is actually connected to a normal standard normal flow meter with maximum of 15 liters. So this is considered a low flow device. But in domestic environment, this is supposed to be used with an oxygen concentrator, which only provides about 2-3 liters of oxygen. So this is how the device is generally used. But in hospital setup, we can use this 15 liters per minute. The device can actually handle up to 30 liters, but unfortunately, these flow meters are not widely available. So if you use in a COVID patient, make sure that if you can get 30 liters. So when you purchase all these devices, make sure that you purchase with a 30-liter flow meter. There's no point trying to give 15 liters. I'll show you what happens when you give 15 liters. And so those are actually domestic devices. These are not hospital grade device, hospital grade for other purposes, but not to give oxygen. This is an extremely comfortable device. I have used this on myself. How it feels and how it functions in oxygenation. I know how it functions because I tested with the oxygen sensors and how different kinds of breathing patterns. So this cannot deliver sufficient oxygen, but it's extremely comfortable ventilator. I have tried almost all the kind of ventilators in my ICU on me with the NIV, so I know how patients feels like. So this is extremely comfortable, very quick to respond, but it cannot provide sufficient oxygen. So I'll show you how. And then you have this device. This is actually getting into Sri Lanka, and people started using this device. This is a portable, very basic device where you, it's called Ventura device. So you can separately control the, you can switch on the, switch on the gases from this switch. You can turn it on and off, and you can control the flow with this switch. You can control the oxygen with this switch, and you can adjust the oxygen concentration, and there is a monitor to monitor the delivered oxygen. Very simple device, but you need some kind of training to operate. There are so many connections to connect, but this is a cheap device where you can give 100% oxygen. This is simply much better than all the portable BiPAP devices, because portable BiPAP can never achieve 100% oxygen, although the company says you can, but it is impossible to achieve 100% oxygen. But these devices, although they are cheaper, they can achieve 100% because this is connected to a wall oxygen. And you can attach to a cylinder, but they have connection to get as much oxygen possible, so that you can attach a higher oxygen flow meter, and this can handle higher flow rate, even 100 liters if the ventilator flow meter, the flow meter can handle. Generally about 70 liters maximum, generally flow meter can handle. So it can handle that flow, and it can deliver higher oxygen to the patient. So these are, so you won't learn in, I mean, you won't understand just by looking at these, but I just told you these are the kind of devices available. You can use standard ICU ventilators, which most of the RHOs will not use. You can use NIV ICU ventilator, which I even don't have access to. And you can use portable ventilators, which I sometimes use to give NIV. And I have a portable ventilator. I mean, I have almost all ICU beds portable ventilators. Anyway, so I use that to NIV also. And you can use domestic NIV devices like, ResMed, Loomis, all these kind of devices. And you can use these portable Cpap devices. This cannot give BiPAP, generally Cpap. Anyway, so when you use a high flow device, as I told you, if you can generate generally, basically, they are connected to the wall oxygen, or using this big tubing to a big cylinder, like a jumbo cylinder, something like that. So high flow devices, they can give 100% oxygen. Low flow devices, don't expect, you can't give 100% oxygen. That is virtually impossible. But theoretically, they will say in a test lung, when the patient with a lower tidal volume, still it's extremely difficult. I don't think anyone can, if I'll just, challenge, but anybody, if you can, with a 15-liter flow meter and deliver 100% oxygen, it's virtually impossible, because as Dr. Anompera said, you need to have a peak inspiratory flow rate generated, which is generally about 30 to 45 liters. You have to either have a reservoir bag, and where you can breathe from that one, or you have to have that flow delivered, high flow. So you have to have a high flow device to get 100% oxygen, or you have a reservoir bag. Like an ambu bag, you can have a tight fitting face mask, you can deliver 100% oxygen. Or you have a tight fitting mask, either say some anesthesia circuit, you can deliver 100% oxygen, but not with these devices. So, so currently circulating devices, these are the devices. So you have a low flow, you can connect this oxygen, low flow oxygen to this one, and it generally mixes. This is the issue. It mixes the room air. It has a turbine. So when the patient breathes with a, we'll say, peak flow of 50 liters per minute, which is a dyspneic patient, normally peak flow is 30 to 45. But so generally it can be 50, 60. When the patient tries to breathe harder, like, things like that. That generally is about 70, 80 liters, but generally dyspneic patients, about 50, 60 we say, because that is the flow we can provide with high flow. So if the ventilator cannot provide this high flow rate, you cannot give 100% oxygen. So because this turbine mixes air, so it will generate the flow. So if the patient tries to breathe 70 liters, it can actually generate even 100 liters. Because this turbine is quite capable. It's very effective, very fast acting turbine. It's extremely comfortable to breathe on, but only unfortunately because it mixes and you have a low oxygen attached to that one, you cannot generate high oxygen concentration. But some people improve because it provides a pressure. It provides a Cpap. It provides EPAP. It inflates the lung. It recruits alveolar. So oxygen might go up, but don't expect it to deliver high FiO2. But it will help the patient. I'm not saying it will not. It will help the patient. But for the moment, this is the kind of device we have widely available. So you will have to use it. But remember that the oxygen is a problem with this device, and try to maximize the delivery of oxygen by having a 30 liters per minute, 30 liters flow meters. So always try to use this fairly high oxygen flow meter, not with 15, but if there is nothing else, you can use 15-liter flow meter. So you can actually, this is how it functions. You have a single tubing attached to a, vented mask, and you connect it to a non-vented mask. You don't use this vented mask which comes with the device. Use a non-vented mask and attach a filter, bacterial viral filter, and attach a exhalation port, and then connect this tubing. So that is how you should connect the ResMed device to a patient. Never ever try to connect the non-vented mask without an exhalation port. It's extremely important because patient will struggle and you won't know, and you will try to tighten the face mask thinking that patient is not getting the pressures properly. So it is extremely important. And so this is, so that is how you connect. So you can attach a humidifier if you want, but generally humidifiers are not that required because you are not going to bypass your humidification system in the throat and mouth, but it's quite drying. So it will help in the long run. But for a shorter NIV, generally you don't need humidification, but longer time, days and days of NIV, it's ideal if you can have a humidifier attached. So when you can attach this tubing over here, this tubing, when you attach a humidifier to the ResMed one. And then, so this is how so if you have an oxygen sensor, please attach, then you will realize how much oxygen the patient is getting. So most of the time, we actually directly connect this to the device without attaching this one. This oxygen sensor, which is called a fuel cell, fuel cell, kind of expensive, and you can attach that to the back of the device called FiO2. There is a cable, you attach that end to that end, and then the other one to the fuel cell. And with the use of a T segment, you can attach an oxygen sensor. So this is the ideal requirement. So when then you will realize how much oxygen patient is getting. Otherwise, you won't know, and this thing will display certain values, but you are not getting enough oxygen, and you don't know how much oxygen patient is getting. So it's the ideal setup, but it's not always available. Okay, and this is the device we have at the moment. Can you mute your microphones? So this is. Okay, this is actually the dangerous device at the moment available cutting into the system. This has no oxygen connection. So what they say is, they say you can connect oxygen to the face mask. But I don't recommend that one. I don't recommend giving oxygen through a face mask because that is not ideal situation, and you don't know what FiO2 patient can. You can't have a high FiO2 with that. So make sure you try to avoid this device, and they will say various methods of having a T junction and attaching oxygen. That is possible. If you have this device, try to do that one. but it's a problem because you can have a barotrauma because your ventilator has got no idea how much flow to generate, and you are giving additional flow that can damage the lung. So in a very junior person, you should not use this device. And if you are using this device, get help from somebody who knows about the device. So how can you improve oxygen? So one of the best thing you can do is to minimize the leaks. So if you have a leaking face mask, and these are kind of problematic, I mean, we can tell these things, but very few people get into the COVID patients environment. And so that is why actually, sorry, the high flow is actually helping because you can provide more oxygen. NIV can provide much better care, but only thing, the mask has to be fitted properly, and when the patient moves around, the mask can dislodge, and you will have to continually adjust, which is practically not possible in actual situation. But somebody can say that you have to go in and adjust, and but who is going to go and adjust? That is a practical problem. But one thing you can, if the patient is, you can actually explain the patient when they are in fairly okay situation before they become quite bad. You can explain the situation, how to adjust the mask, and importance of keeping the mask. But once they are listening, they won't listen to you, and it's kind of difficult task to do. Anyway, so that is important to have a proper fitting mask with minimum leak. And the other thing is to use this 30 liters per minute flow meter. It appears the same, but you can see it's actually 30 liters, and you can even give more than 30 liters with these flow meters, and then have a way of connecting that flow meter to the oxygen cylinder. But unless it's a jumbo cylinder, this thing will disappear very fast. So if you have a pipeline and you have this device, so you can use a 30-liter flow meter. The device can handle only up to 30 liters, but I have tried that device with 70 liters, but still nothing really happened, but it's not recommended. So use a 30 liter per minute flow meter. And additionally, you can use this kind of a gadget, a T-piece, to have some more oxygen. But as I told you, because the ventilator does not know this is happening outside the ventilator, or outside the NIV device. So this flow and the ventilator flow, both these flow can actually cause some barotrauma or pressure injury to the lung. So it's not really recommended, but this is an option. So when you have one of those devices, but get the help from a senior person when you do that. The other device is a portable ventilator, which I'm going to talk about in the next session, but I'll just touch upon this one, portable ventilators. So how can we use NIV when you don't have an NIV ventilator? So you can actually use any ventilator which has got a spontaneous mode. So spontaneous mode means you have a Cpap, baseline pressure, and when the patient breathes, it raises the pressure. That is basically a BiPAP. Although the ventilator manufacturers, sell these devices at a higher cost, BiPAP devices, this is basically the same thing. The only difference is how the breath is sensed. Now, this device, the what is this? Flight 60 ventilator, portable one, but it has got a sensor at the patient's airway. So this, you can see this, there are certain tubings going from this thing. So actually it senses the breath at the patient's airway. So it is quite sensitive and it's quite comfortable. I have tried this one also. This is actually quite comfortable ventilator to breathe on because it senses the patient's breath very easily compared to a ventilator where the sensor is actually inside the ventilator. But here the sensor is at the patient's face mask. The moment you try to breathe, so that will be detected by the ventilator and it will help giving some support from the ventilator. So if the EPAP setting is just use the Cpap. IPAP is the Cpap plus pressure support. So that is your IPAP settings. For example, if you want to get a pressure limit, so EPAP, IPAP settings of this is how we mention the pressures. We say 13/8. So generally 13 means the IPAP is 13, 8 means the EPAP is 8. So what you can do with this ventilator is you can have a Cpap of 8. And then there is a gap between 5, these two. So you can have a pressure support of 5. So you get total of 13. So the IPAP of 13 is taken by a pressure support of 5. So that's how you set the ventilator, and this will usually well function as a NIV ventilator. But you must have seen there are certain buttons in the ventilators, like NIV mode in a say Newport ventilator, or NIV on off. If you go to settings in this particular ventilator, there is a thing called NIV on, NIV off. So it's not actually visible. You don't have to change it. But if you change it, only thing it causes is it just minimizes some of these alarms, because if you just don't tell the ventilator or don't tell the portable ventilator that you are in NIV mode, and then you connect the patient and it looks for leaks, and NIV, you have leaks everywhere. I mean, you try to minimize the leak, but it's inevitable. You have some kind of leak. The ventilator will start alarming that there is a leak, things like that. So if you go to NIV mode, it's not going to change anything. It's just that deliver the pressures the same way, the turbine and everything, it functions the same way. The pressures are the same, everything is same. The rate is same, everything is same. Only thing, it will change the alarm settings. So even if you don't change to NIV mode, it's not going to cause any significant harm. Only thing, you will have so many alarms, and it's kind of a nuisance to have so many alarms. So always, if you can change into NIV mode, then you will have less alarms. Otherwise, if you use a spontaneous mode with the Cpap pressure support, that is the NIV mode. And this particular ventilator has got a sensor at the patient's airway, so it's kind of out of the portable ventilator. This is preferred for NIV because it senses much better. I have personal experience in putting the devices. This device can sense the patient breath quite easily. So what devices we can use? We can use any portable device with spontaneous mode, pressure support mode, provided it can compensate for leaks. So some of the devices, they can compensate for leaks. So those devices are not that suitable. So basically, most of the devices are capable, the new devices. But if you have a, say, Acoma ventilator, don't try to use Acoma because they don't have spontaneous mode. And then so you can't use that ventilator. You can, but it's not ideal. The patient cannot ask for a breath. It's not BiPAP. It's some kind of a weird kind of ventilation. Don't try any ventilator, but try to use a ventilator with a spontaneous mode or Cpap support mode with some degree of leak compensation. You can ask from the manufacturer, or you can ask from somebody, anesthetist, whether this can be used. So you can get some idea about whether the existing ventilator can be used. And don't use the portable BiPAP devices if you don't know whether you can add oxygen, how you can add oxygen. So when you use a BiPAP, so ResMed Stella is capable of giving BiPAP very nice. The ResMed devices are okay, but only thing, the oxygen concentration is a problem. But unfortunately, you will have to use that one because that is the device available. So this particular device comes with single limb arrangement and a dual limb arrangement. So if you have a single limb arrangement, so this is actually the flow meter, but dual limb arrangement, so you have to use a filter over here, but dual limb also possible. In that case, you can use a non-vented mask without exhalation. So here, of course, they have a valve over here. So there is a valve at this end. So you don't need additional exhalation valves. So this ventilator, even with the single limb, it can provide exhalation easily at this port. So it's actually controlled by pneumatically controlled, and it closes on and off during inspiration and expiration. So this is kind of a smarter device to provide both invasive and non-invasive. Basically invasive ventilation, but it can provide non-invasive too. This is not an NIV device. This is an invasive portable one, but it can give NIV very easily with this device. Okay, so you start certain settings, and settings you generally start with a lower setting, and then you gradually go up. You can look at the guidelines you have in the. So I'm not going to discuss the guideline because they keep changing. But generally speaking, you can start with the lower pressures, lower PEEP or lower EPAP, and then lower pressure support, and gradually work on the pressures, the EPAP or the pressure support, until the patient settles. Otherwise, if you start with a high flow rate, high pressure limit, it is invariably associated with high pressures, high rapid pressure development, and patient is find it uncomfortable. And then how do you know whether the patient is failing? So I'm not trying to give you a certain guideline, but you can see, I mean, the patient saturation, whether it is improving, what happens to the respiratory rate, how does the patient look like, whether they are comfortable, whether the respiratory rate goes up. So you can use the various, scoring systems. But basically, I would go into details of those things, but you can just look at the patient. If you do blood gases, you can check whether the oxygenation is improving, whether the PO2 is going up, whether the CO2 is coming down. So when there is a failure, so how long are you going to wait? I mean, this won't happen within a 5 minutes sometimes. Sometimes it happens, but sometimes it takes a couple of hours. So you can wait for a few hours to see whether the NIV is working. And always adjust the mask so that there is less leak, and you explain the patient, reassure the patient. So those are the important steps. More than adjusting the pressures when the mask is leaking, there's no point increasing the EPAP because the mask is leaking. Patient is not keeping the mask on the face because it's too tight. So advantage is you can take the mask out, eat and drink and keep the mask back on. And generally we place a NG tube, but you can, if shorter ventilation, you can actually omit the NG tube, but it's advisable to have an NG tube because with these pressures, especially if you use higher pressures, then you must put an NG tube because the high pressures will inflate the stomach and it will hamper the diaphragmatic movement. So it's always better, especially if you use high pressures, place an NG tube to deflate, and especially so you can have a certain degree of leak through the NG tube, but don't worry about that one. It's not a very big leak unless you put a very big NG tube and a very loose face mask, but generally you can tighten a little bit. And then, so how do you detect failure? You might hear certain sounds, leaking sound, but bigger leaks, you don't hear anything. There are ways of checking by expiratory flow wave of wheels. I'll try to show you if I have time how to detect that one. So what will you do when the NIV fails? This is very important. So as a junior person, you should always inform your boss about the failure. And so NIV, when it fails, generally it's much better if you have facilities to intubate and ventilate, and then go ahead with intubation. But it's not a common option nowadays because there are no widely available ICU beds, and there's no point, trying to intubate if you don't have a ventilator. So you will have to keep the patient on NIV and then try to optimize all the, mask and everything. But when it fails, you have to communicate the failure, like the saturation is not big enough, saturation is dropping, blood pressure is dropping, these kind of things. Saturation, those have to be communicated. And then early, if you try to switch over to a invasive ventilation early, probably you can save some of these patients, provided you have ICU bed, provided you know how to ventilate in an invasive, because invasive ventilation is not a treatment for COVID, but we do it in desperate situation until the COVID, with the body sort out the infection, or you give some medication to suppress the immune system or the virus and everything. So underlying management. So you just try to manage the patient's life with these devices. They are not at all treatment modalities. They are just treatment in the sense it won't treat the underlying pathology. It's a treatment modality, but it's not going to treat the underlying pathology. It will improve the oxygen, but it won't cure the underlying pathology. So you have to do something for the underlying pathology, maybe immune therapy, maybe antivirals, so many different kind of things. Okay, so NIV fails, the mortality high. That is what the current evidence says. But it's not probable because of the NIV. Now, you can't blame the NIV. It's the improper application most of the time, and you don't switch over to the proper way of managing, and you probably keep the patient too long on NIV. But unfortunately, at the moment, with the current situation, so that's there can be a situation you might not even get a NIV or even oxygen for certain patient with the COVID worsens. So all these theories we talk about, it's gonna go down the drain when you have rapid surge of patients. So, but you try to get in the optimum way whatever the available facilities. So NIV makes sure that it's not a specific treatment; it's just a bridge. So if it is not indicated, please do not use that one. So if you need oxygen problem, use oxygen methodologies. I mean, all these the high flows, non-rebreathing mask oxygen, which can provide a very high oxygen compared to these portable BiPAP devices. But when you need the breathing support, like work of breathing, so high flow cannot provide sufficient work of breathing, non-rebreathing mask cannot provide sufficient work of breathing, then you can actually switch over to BiPAP devices. Although it provides less oxygen, probably the patient feel better, and it might recruit some of these alveoli, and it might even increase saturation. So as I told you, it's the EPAP and the FiO2. So the non-rebreathing mask, there is no Cpap or EPAP, but it will increase oxygen. The respiratory device cannot provide enough oxygen, but it will provide EPAP. So it will recruit some of the alveoli. So what will happen? You'll have to just, try and error method when the oxygen, when you fail giving oxygen, and then if there is no other high flow device, or if you don't have any high oxygen device, probably you can try the domestic BiPAP devices and try to ventilate this patient. And the oxygenation is not adequate, try to use the maximum flow available in the flow meter, 30-liter flow meter most ideally. But if you have 15 liters, try to increase it more than 15 liters. I mean, it marking goes up to 15, but if you increase it a little bit more, you get more than 15 liters, depending on the situation. I mean, it's not very high value, but still slightly more than 15 liters. So even that amount will help benefit the patient ideally. I have a certain scenario. I think I have about another 10 minutes. Yeah, about 5-10 minutes. I'll try to discuss one certain scenario which is important when you connect NIV to patient. This is very common in hypoxemic patients where they have been quite sick at home, and when they come, they are dehydrated. So this is a real situation happened in a certain hospital. This is a 65-year-old lady, the diabetic patient on oral hypoglycemics. She came with fever, cough, and shortness of breath. And then she was saturating around 90% on a face mask oxygen, 10 liters, about 60% oxygen. And she had a sepsis due to pneumonia. And the emergency department, they applied a Cpap of 50. Because at that particular unit, they start with a high pressure. I generally start with lower pressure and then go up, and then use the minimum available, minimum needed to get my target. But there are certain guidelines. Some people apply high values. So particularly in this patient, they apply 50, and saturation improved 100% instantly. But the urine output dropped to 5 mil, and 10. And then, so because people are worried about giving fluid, because they say fluid can get into the lung in a pneumonia situation, so they use furosemide instead of giving fluid. Urine output improved to 25, 30, 20. And then later, blood pressure started dropping, and they started some noradrenaline, because that's the kind of magic drug everyone talking about when there's hypotension, start noradrenaline. And the next day, the patient was on 2 inotropes on high doses. Urine output worsened, and patient went into an acute kidney injury and died with sepsis and multiple. I'm not saying that I can save this patient, but we have to think about what really happened. So it could be the sepsis, worsening sepsis jolly well. I mean, that could be the main reason. It could be this, when you use high pressures, when the patient is hypovolemic, that affects the venous return. So that affects the blood coming into the heart. So that drops the cardiac output. So when your cardiac output is dropped, so oxygen is delivered using bound to hemoglobin with the cardiac output. Cardiac output is the utmost important parameter in oxygen delivery, not the saturation. Saturation is important to get an idea about how the lung is doing oxygenation. But whatever the oxygen saturated has to be delivered by cardiac output. When there is no cardiac output, less cardiac output, that is the number one factor affecting oxygen delivery, not saturation, not hemoglobin. Hemoglobin, saturation, and cardiac output are the 3 main important parameters. But out of these three, cardiac output is the most important, which is not measured in this patient. But there was an indication that the cardiac output is low because urine output dropped to nil and 0 and very low values. So you would have done something to that one, maybe reduce the pressures a little bit to get a saturation of maybe 95% or 94% instead of 100%. Could have saved the kidney. Or you can give some fluid, or you can minimize the doses of vasopressor like hypovolemia, noradrenaline is a very bad combination on kidneys. So if you have good volumes, though it will spare the kidney, it might even improve the renal function because you have enough volume and you vasoconstrict, and that will improve the blood flow to the kidney. But if you are hypovolemic, the body will try to vasoconstrict the splanchnic, the skin, and next the kidney. So it depends on the volume status. What happens with the noradrenaline? Don't think noradrenaline is the best choice in each and every situation, but you have to give volume when the patient is hypovolemic. So that is one message I want to tell you. Oxygenation is just getting oxygen into the bloodstream. Oxygen delivery is delivering that oxygen to the tissues. So there's no point hampering the cardiac output and improving oxygen. So this is crucial, physiological and proven stuff. So you must always make sure that your pulse volume is good and your output is okay. Don't give furosemide when you get your low urine output. When you apply high pressures, adjust the pressure, maybe come down a little bit, and when give some volume, maybe you can go up after that. Or you use some other drug where you will increase the cardiac output also. So that is how you should manage. There are so many indicators. I'm not going to talk about indications, and these are kind of boring, and you can decide when the oxygenation fails. You can read about these things. And generally, this is well tested for hypercapnic respiratory failure, like in COPD. I'll just skip these slides because this is where at the moment, we are trying to apply these things on COVID patients. So basically, it's not really indicated in hypoxemic conditions, but generally, it's not really not indicated, not proven to be beneficial, but there's nothing else we can do at the moment. So we'll have to use. But there are certain contraindications I would like to. If the patient cannot protect the ARV, like in a comatose patient, or so agitated, confused patient, don't use NIV. So they might aspirate, they might vomit, they might aspirate. And when there is hemodynamic instability, like very low blood pressures, needing very high inotropes, so maybe that's not the ideal thing to do. And say when there is severe vomiting, you should not apply because patient will have a very bad aspiration. And there is copious secretions. So this is one indication, but like a little bit of secretion, you can actually still apply. I have tried this one in COPD patient, and they have secretion, but you apply, you ask the patient, you take the mask out, ask the patient to cough out. If you can do that, you can apply NIV, but copious secretions, like, say OP poisoning patient, things like that, or there is a lot of secretion coming out and kind of a terminal stage, you should not apply NIV because you're going to have a bad aspiration. So those are the kind of contraindications. And this is the kind of normal theory. People think if you have low carbon dioxide, you apply Cpap. You have high carbon dioxide, you apply BiPAP because it provides. So this is fairly okay. It works in many instances, but my teaching is, so you try to use BiPAP all the time. You can reduce the pressure support if you don't need big BiPAP, because it helps the work of breathing. And most of these people where we apply NIV, they are having a work of breathing issue. It's not simply oxygen. So for example, if you have a drowning patient, they have oxygen issue, but they have a work of breathing because there is a water layer inside the alveoli. So you need to sort out the work of breathing also. It's best if you can apply BiPAP in my teaching, but generally this statement is true. If you have a low Cpap, low carbon dioxide, you can apply Cpap and the carbon dioxide might come up, but I don't really see any scientific theory, the reasoning behind it. But fairly okay. But it is a normal teaching, so I don't want to talk about it too much. But generally, I would prefer you to use BiPAP all the time and use the pressure support, adjust the pressure support, high or low, depending on where you need to control the carbon dioxide. And it's okay to wash out some of the carbon dioxide, and they won't hyperventilate to down to a zero carbon dioxide and have a cardiac arrest. That won't happen. And they will control. Once you improve oxygen, their breathing will settle, and the carbon dioxide the brain will control. And it's not actually the carbon dioxide. So I mean, when you have a hypoxic condition, patient is breathing fast to get more oxygen. That is the reason why you have low carbon dioxide. So once the oxygen is corrected, they won't breathe that fast, and the carbon dioxide will not wash off that fast. So anyway, basically, so this is what I want to discuss. So I'll stop here. So basically, what you need is you have to treat the underlying cause. NIV is just a bridging therapy. There are two main ways of giving NIV. The Cpap. There are different devices. I can't go through each and every device in detail, but basically Cpap provides a continuous positive air pressure. It helps the patients to breathe in but not breathe out. So because of that one, so it's basically used for hypoxic conditions where you will get more oxygen, you have a better lung volume, but it does not provide kind of ventilation. So BiPAP provides ventilation by way of having two pressure limits. When the patient breathes in, you raise the pressure up. And then when the patient breathes out, you drop the pressure. So it helps inspiration, expiration, better tidal volume, better ventilation. So BiPAP is, so when the BiPAP fails, you look at the patient, respiratory rate, oxygen values, all these things, and you can decide. So within a couple of hours, generally, you select whether the patient can be, so you need to go for invasive ventilation. But basically nowadays, so that theory is no longer 100% valid because there are no widely available ventilators. You may need to continue in NIV for a prolonged duration as long as you get a bed. But always look at the patient. Don't try to, so look at the patient, whether the patient's mask interface is good, whether they have proper mask fit, and select the proper mask. Explain the patient, extremely important, about the consequences of not maintaining the mask and the importance of keeping the mask with this and cooperating with the machine. Oh, I hope I gave you some kind of idea about NIV. There are so much to discuss, but I probably was too fast because I wanted to include most of the stuff. But you can contact me at any point. All these RHOs, if you have any issues, you can either call me, you can WhatsApp, and anything. You can get my contact number from the hospital. I'm glad to help you at any point if you have any issues, in technical issues, and how to. And if you need more training, even I can provide that one. I hope you learned something, at least 25% of what I have told you. Yeah, I will conclude my lecture here.